This is a 66-year-old man who presented for a diagnostic runoff. He is a diabetic and has gangrene of his second and third toe on his right foot. Our surgeon requested the arteriogram to evaluate him prior to performing a bypass graft. He prefers diagnostic arteriography to MRI and CTA. Using a right femoral approach, a catheter was placed in the midstream of the aorta and a midstream arteriogram was obtained. There are single renal arteries bilaterally. The infrarenal aorta shows no significant disease. The inferior mesenteric artery is open, and there is no significant common iliac artery disease. The external iliacs show no disease, nor do the common femoral arteries. A right posterior oblique view was obtained, demonstrating widely patent external iliac and internal iliac origins, as well as the left common femoral artery bifurcation, which demonstrates a large profunda and a tiny superficial femoral artery. A left posterior oblique view reveals a large internal iliac and external iliac on the right with no significant disease, as well as a large right profunda and a superficial femoral artery with no disease on the right side. Mid-superficial femoral artery disease is seen throughout the course of the right side, and severe left mid-superficial femoral artery disease is seen on this film. The surgeon requested no additional information on the left side, so the catheter was removed and continued studies were done from the sheath on the right side. The distal superficial femoral artery and proximal popliteal artery are occluded. There are large bridging collaterals to the mid and distal popliteal artery, and there is a 50% stenosis of the distal 1/3 of the popliteal artery. At the tibial perineal trunk, there is a high-grade stenosis. The anterior tibial artery is occluded. The perineal artery is quite small, and there is a 50 to 60% stenosis of the proximal 1/3 of the posterior tibial artery. The distal posterior tibial artery reveals a 30% stenosis just as it crosses into the ankle. The posterior tibial artery is continuous and crosses into the foot. There are some collaterals that are poorly developed to the dorsalis pedis artery. However, the vast majority of the flow to the foot is via the posterior tibial artery. For further information, please contact me at tpmmd@hotmail.com. Thank you for your attention.